everyone on the call. So I'll be taking you through Zambia's experience with resource mobilization and the investment strategy for the SRAS in Zambia. So I wanted to start with just a few examples from country-specific initiatives which have gone to try to understand the current gap in mortality surveillance systems in the country. As we all know, a complete and timely CRVS is the best source of mortality information. But unfortunately, in Zambia, like so many lower middle income countries, most of the CRVS is unfortunately incomplete. And so these are findings that we conducted from a baseline census of mortality surveillance systems in Zambia. And what you're seeing on your right is a map which is currently showing provincial level completeness of death notification to the CRVS in Zambia for the year 2020, which is when the last CRVS was produced. And you could see from highs of about 35.7 on the Copper Belt and 52.3 in Lusaka, which are two of our most urban provinces. But this slowly fades out as you move to more rural provinces, with several provinces registering deaths with less than 1%. And so this really does indicate how the low level of completeness in terms of the CRVS in the country. And if you actually look at the graph on your left, this then actually shows that this is not only a one-off finding, but rather has been a systematic finding where we actually see quite low levels of CRVS completeness over the preceding 4 years. The gray line there shows what the estimated annual deaths in the country should be, which is just slightly over 200,000, but we have been consistently notifying deaths at just less than 50,000. And so you can see that without any interventions, this actually makes the use of the data that is coming through the CRVS system currently not very ideal for making data-driven decision making, and also in terms of using this information for public health security or surveillance purposes. So this really does present a compelling picture for the need for alternative or complementary sources of mortality data, which can actually provide the required information to not only address those earlier two concerns, but then to also be the backbone upon which other CRVS strengthening activities can actually be initiated. And the cost of this data gap in the country was perhaps not most apparent during the COVID-19 pandemic. I'm sure for most of us on the call, we are familiar with a term that was coined, I think it was called the African COVID-19 paradox, where in the initial phases of this pandemic, there were actually there was a gloomy picture painted of the scenario in terms of mortality patterns on the continent. But however, this was not seen in terms of expectations of hospitals filling up and really having a high mortality rate. And there were several theories that were advanced to explain this apparent paradox, including issues around immunogenicity, vitamin D deficiency, and others, such as the demographics of the population in Africa being much younger and therefore being more protected. But really, although this is still under debate, there's another angle to this, is that do the systems that actually count mortalities in the West, are they comparable with those in the African setup? And numerous studies have been done that have actually shown that most of the CRVS systems on the African continent are actually incomplete. One such actually intervention found that within sub-Saharan Africa, death registration completeness remains on average below 40%. So with such a low death registration coverage, can such a system actually be able to capture mortalities happening across several places? And so when coming to the Zambia specific example, when we actually conducted targeted interventions to try and measure the scale of this pandemic in Zambia, we actually found that there was quite substantial mortality that was recorded. And this was largely undetected, primarily because of the location where these mortalities were happening. So these mortalities were not happening as you would expect within the hospitals, but they were actually happening within the communities where current public health surveillance systems were not able to actually detect these deaths. In the country, we actually estimate that for every one reported COVID-19 death, about 44 deaths were actually excess, which puts the total excess mortality recorded over this period to over 44,000 compared to the 400 reported deaths over this entire time period. So I wanted to show this example because unfortunately, this particular study was a retrospective analysis, and this data was only available 2 years after the pandemic had occurred through a retrospective data analysis initiative. Looking back, if this information would have been available as the pandemic was progressing in the country, could this information have led to different decisions with regarding to the various interventions that were put in place to help mitigate this pandemic? Could this information have been used to lobby for more equitable vaccine distribution and earlier vaccine distribution on the African continent to actually prevent further deaths? So we actually see that the lesson from COVID-19, I think, is very clear, and it's really not a matter of if the next pandemic will hit, but rather when. And if the current mortality surveillance systems actually remain in the current state, we actually risk seeing a similar picture on the African continent. So as William had mentioned, these gaps actually make a very compelling investment case for a timely and representative mortality surveillance system that is able to provide information in near real time. And this system is supposed to produce these indicators that will actually be useful for not only routine public health surveillance, but also health programming. And this information will be collected on a nationally as well as provincially representative scale. So how did we approach building an investment case for the SRIS in Zambia? So the first step was laying the necessary foundation groundwork. So this meant preparing or putting in place the necessary teams and systems to be able to generate this particular investment case. So one key step that was taken during the COVID-19 pandemic, largely in response to the absence of timely and reliable mortality data on the mortalities currently happening during that particular pandemic, was the establishment of a dedicated mortality surveillance unit within the Surveillance and Disease Intelligence Department at the Zambia National Public Health Institute. This unit's mandate was solely focused on coordinating and strengthening mortality surveillance activities within the institute and as well as across the entire country. Then the next thing was beginning to, as part of the foundational groundwork that was laid, was the establishment of an interministerial coordinating mechanism So beyond the National Public Health Institute, developing a body now that coordinates the mortality surveillance activities within the country. So within this subcommittee, different stakeholders across the different line ministries in the government involved in some way with the production or use of mortality statistics were brought on board and then began to meet regularly to begin to understand the challenges of mortality surveillance in the country. And then from these collaborations, we began to then prepare a roadmap for how mortality surveillance activities in the country could be strengthened in line with CRVS strengthening, as well as the digital transformation strategy. Next, we were then able to begin stakeholder mapping. So this was done with the support from the Africa CDC, who helped us identify who the different stakeholders are beyond the subcommittee, and even within the subcommittee, to better understand the different roles of each stakeholder that was present on that particular committee. So the approach that we used was looking at how data is produced within a mortality surveillance system, from the data collection all the way to analysis as well as dissemination. And then critically looking at who are the different stakeholders involved at each particular stage. And then also looking at the different intricacies of how, or the different intricacies of an SRIS, the representative platform at national and provincial levels. What stakeholders would be interested in such a platform? Then also having a continuous community-based data collection personnel who are embedded within the community, really begin to identify, other than for mortality surveillance purposes, what other stakeholders would be interested in having these data collection personnel at the community level. And then also looking at the emphasis on digital integration, as well as systems interoperability. So looking at these three frameworks, we're able to then try to understand who are the different stakeholders who are currently doing activities within this space. What would they have an interest in partnering or co-financing the SRS? And this really helped us to identify additional stakeholders. So as we did this stakeholder engagement, we began to refine what the value proposition for an SRS would be. And I won't go over these, as William had done an excellent job mentioning what the different ones are. But from the Zambian perspective, one thing that we were emphasizing as we engaged the different stakeholders that we would be engaging was the emphasis on adaptability. So that is one. Yes, the SRS is a mortality surveillance platform, but within that platform, several other initiatives, activities, studies could actually be implemented in that nationally and provincially representative sample. So this, again, was a very strong pitch that we would advocate as we engage the different stakeholders, and showing how these different stakeholders can actually leverage the SRS for some of the other activities that are aligned with their institutional objectives. Then the other point was on the representativeness, as well as the ability to produce timely mortality data that not only supports the CRVS in terms of ensuring in closing the gap in terms of birth and death detection, but also providing support towards pandemic preparedness, as well as public health action through program evaluation. Then finally, we were framing the SRS really as a public good, a system that has cross-sector benefits across health, across home affairs or CRVS, across the finance or planning ministries, as well as the various academic institutions within the country. once we had refined this differentiated engagement pathway, which would be suitable for various stakeholders across their different specialties, we then had to now come up with how do we engage these different stakeholders in the fourth and final step. So we had the initial dialogues through members of the subcommittee in those particular meetings where we would meet with the Ministry of Health, Ministry of Home Affairs, Ministry of Local Government, as well as local partners such as the US CDC, the Global Fund, and of course, the Gates Foundation. And another key engagement strategy was the use of already existing mortality information. So as part of one of the significant findings from our baseline census was that it's not that mortality information is not being collected in some way across the country, but rather the use is often limited. So we had a direct strategy of using whatever available mortality data was there to really demonstrate gaps in commonly held beliefs, as well as also to demonstrate the capacity and to generate the necessary interest in mortality surveillance as a whole by using any data that was available. The study I had shown earlier on excess mortality was primarily conducted using based hospital registers, which were only the only source of reliable information across the pandemic in the country. And so once we began to engage the different funders, we were then able to identify or classify the different funders by the type of potential funding source. So two funding mechanisms became apparent to us. One was direct financing, where the project or the initiative would actually receive actual funds from the different partners. And the other was indirect. So with indirect financing, this was non-monetary, where support would be offered to the project in terms of either equipment or human resource to support the project. So there were again two differences between these two particular funding approaches. With the direct financing, where the money was available to the project, these were unfortunately more difficult to secure. You'd have to have often a lengthier or a longer engagement processes with the prospective funder. And also you'd have to adhere to strict guidelines in terms of the use of the resources as well as reporting. But by and large, these were easier funds to manage as they were often predictable, where you would receive the funds and you would actually better utilize them over a certain specific period. With the indirect financing, however, these were easier for us to secure, usually through institutional commitments that an institution would be able to provide some support towards the SRIS, but would be a bit more difficult to manage and sometimes could be a bit unpredictable. So by and large, the figure on the right shows what the final distribution for funding for the Zambian SRIS looked like, where we see the majority of funding coming through the Gates Foundation, followed by the US CDC that provided direct financing. And then we had support in terms of support towards project equipment from the National Public Health Institute, as well as the Global Fund. So this really just shows that funding across different partners and sectors can actually come in different forms. So some of the challenges and lessons learned was the benefit of continuous stakeholder engagement and feedback. The implementation reality on the ground in most countries would be different And so oftentimes you'd find that what was planned may not actually be feasible on the ground. And as such, you might need to, one, readjust your initial designs or initial approaches, and this may have cost considerations. So it's important in this particular process to have this continuous stakeholder engagement, alerting them of any challenges and feedbacks and any changes to the program design. Then it's also important to approach stakeholder mapping, not entirely from the mortality surveillance or a CRIVS perspective, which are core perspectives, but then looking across the different stakeholders. And the initial stakeholder mapping across the different functional areas of the SRS actually helps you to identify who the different stakeholders are that would actually benefit from the different design intricacies of an SRS system. Then also consider direct and indirect financing. In cases where you are not able to have direct financing, an additional option is to opt in for indirect financing, which may actually help to reduce your overall cost of the SRS implementation. I think a very key consideration is that you need to try as much as possible to have a minimum viable product of an SRS within a dependable and predictable funding. So this will allow you to navigate any challenges that you might have as other funding sources might become scarce. Then last but not least, we have really experienced the power of visibility as we document several activities that we've been doing through regular print. And this really does bring on board even other stakeholders who actually see some of the activities being implemented. And these are stakeholders that we could have missed in our initial stakeholder mapping. So the visibility in terms of implementation really does help to bring on additional stakeholders that you could have missed in your initial stakeholder mapping. So in conclusion, I'd like to reaffirm that the gaps that are created by gaps in mortality surveillance actually could lead to loss of more lives, and mortality surveillance is actually integral to proper public health and developmental planning. We need to approach the SRS as a cross-sector public good that can bridge this gap. And though co-financing is key to sustainability, care must be taken to ensure that within predictable funding, you're actually able to secure funding for a minimal viable product that will actually be able to be a greater advocacy too. Thank you so much for the attention, and my presentation ends here.
Thank you, Stephen. Fantastic presentation and a great practical example from Zambia, and also with the COVID-19, very hands-on presentation. Thank you very much. I'm sure everyone appreciates the practicality of it. We kind of ran out of time. Maybe we have time for one question, and otherwise I would encourage anyone to get in touch directly with Williams or with Stephen for concrete questions, or also send it to us. But if we have like one comment, I see already a hands up. Please just unmute yourself as Dr. Oti, and then yes, we can take that one question. Please, I'm not sure if I'm saying the name correctly. I don't know if Dr. Oti or Drotip, but please.
Yes, yeah, thank you. No, thank you so much. Really, Dr. Droti from WHO Regional Office for Africa. I really enjoyed listening to both presentations from Dr. Chanda and also from William. I think these are really great presentations. They put really in place the value of sample registration systems. I just wanted to share that one area we should, start bringing into the conversation is the value of SR generating data for predictive analytics, which really helps countries to anticipate events and anticipate risks going forward, so that we are not just looking at counting births and deaths, and also using the information to predict some of the events in the future. It came out in both presentations as well. And we could now start leveraging the power of AI, machine learning, and bringing that and start building models that enable countries to anticipate future events, map to event surveillance using this specific data. That will be another huge value that SR will bring to countries. Thank you.
Thank you very much for that comment. I think for the sake of time, we can end the session here. But again, I encourage everyone to reach out to Stephen or Williams or to me, and I can also just connect you to them. Thank you everyone for attending, especially Williams and Stephen for your fantastic presentations. As usual, they will be circulated and uploaded to the Viva website. So you can also resort to them for now for the countries as great examples as you move on with the protocol and with your plans. Thank you very much to everyone and take care.
Bye bye, everyone.
Thanks, everyone.